Hey, Mike Gibson, Dominick Angiolillo, talking about how do you de-escalate from Ticagrelor down to Clopidogrel and from Prasugrel down to Clopidogrel? Common question, Dominic. Give us the scenarios and what you do.
Well, thanks, Mike. So this is what we call a de-escalation by switching drug, which is a very, very common scenario, and can happen for a number of reasons. We can need to de-escalate sometimes because of costs related to the medication, side effects, which sometimes may include bleeding and non-bleeding side effects, particularly the dyspnea when using a ticagrelor. And there are two broad ways where we can de-escalate, at least in our uh, uh, recent consensus definitions. We can de-escalate by in a guided way, in other words, using platelet functional or genetic testing, or in an unguided fashion. These are the two big ways. In general, if we are to de-escalate in an unguided fashion, in other words, not knowing what is going to be the individual response to clopidogrel, the recommendation is to try to delay this as much as possible, because studies of early de-escalation have shown an increase in thrombotic events. So in general, we want to wait at least 30 days. And this was done in the trials that actually showed particular non-inferiority of this strategy. Uh, and if we're doing a guided phase, we can do a little bit earlier. But again, there are some challenges with doing that based on the assays that you do have available. Personally, I'm a little bit more in favor of a guidance using genetic testing because your genes don't change, and you don't need to put your patient on clopidogrel to actually see the response to clopidogrel. A general concept from a practical perspective, if you are de-escalating and you're de-escalating early, when I early by early in our definition, we say anything within like the first 30 days, always switch with a loading dose. Always switch with a loading dose. So just give the 600 milligram of clopidogrel. I always say go big or go home. There's no
600,
downside.
not 600, not 300.
600, yes, 600. And we've actually done some pharmacodynamic studies to support this, particularly when you're de-escalating from from ticagrelor to clopidogrel, so switching in classes from a non-tynopyridine to a tynopyridine, very similar to what we've observed with Cangrelor, Mike. There is a potential for a drug-drug interaction. And so we always want to give a loading dose. And it doesn't matter if you're giving it 12 to 24 hours after the last maintenance dose of ticagrelor.
But
The,
you would want to wait
a
12 and
little bit, you want some of that offset of effect of ticagrelor. So these new active metabolites of clopidogrel can go and bind to the unoccupied P2Y12 receptor. You don't want to give it too close because then it's just like what happens with Cangrelor. Uh, you're going to have the receptors occupied.
Mhm.
Shifting from prasugrel to clopidogrel is a little bit different. Now, if you're doing it really early, I still recommend giving a loading dose of clopidogrel. If you're doing it at 30 days, I would say it's fine to go to maintenance dose because prasugrel being an irreversible platelet inhibitor, and you still have effects on platelets for 7 to 10 days, and we've seen this in some of our PD studies. That still gives time for clopidogrel to kick in. Okay, that 1 week period. So these are my general recommendations, but particularly when going from ticagrelor to clopidogrel, which is the most common de-escalation happening nowadays. If you're doing it in an unguided fashion, please try to wait for 30 days. You know, we have a lot of these patients with dyspnea earlier. Just tell them to patients to hang in there. Don't stop, please, the P2Y12 inhibitor in a patient with a recent acute coronary event. And if you do need to de-escalate, just give a 600 milligram load 12 to 24 hours after the last maintenance dose. This is what we put in our international consensus document, supported by pharmacodynamic data. We do have registry data showing rebounding clinical events and thrombotic events, particularly if this when you have the de-escalation done within the first 24, 48 hours, particularly if not using a loading dose, and it's all attributed to a drug interaction, and your crazier platelets in the first 24, 48 hours after an acute coronary event. So these are my recommendations, kind of tips and trips for clinical practice.
Great. So whether it's acute or chronic maintenance dosing, if you're going to switch from Ticagrelor to Clopidogrel, wait 12 to 24 hours, give 600 milligrams of Clopidogrel, and then you go on with your maintenance dose.
Absolutely.
Okay, great. Dominic, thanks for joining us. Thanks for a great episode here of Snackable Health. Hope all of you enjoyed it.
Thank you.